Welcome to this lecture on tackling antimicrobial resistance. There are two main areas that I'm going to focus on in this lecture: digital antimicrobial stewardship tools and pharmacy professionals' contribution to tackling antimicrobial resistance. My name is Professor Diane Ashiru. I'm the lead pharmacist for antimicrobial resistance at UK Health Security Agency. I also have an honorary lectureship role at UCL School of Pharmacy. The learning objectives that I'm going to cover over the next few minutes are around the key national actions to tackle antimicrobial resistance, including the UK Health AMR Action Plan, the current national data on antimicrobial use and consumption, key antimicrobial stewardship interventions that have been developed and available for use, focusing on those that are available digitally, pharmacy professionals' contribution to tackling antimicrobial resistance. I'll touch very briefly on applying behavioral science principles to developing antimicrobial stewardship interventions, and I'll end with the AMR data and analytical tools that are available for antimicrobial resistance and stewardship, including the local indicators on OHID fingertips. I've provided a list of suggested reading which goes around antimicrobial resistance broadly, so the English Surveillance Programme for Antimicrobial Utilisation and Resistance and Target Antibiotics Toolkit Hub, as well as the UK AMR National Action Plan. In tackling antimicrobial resistance, there's been significant amount of work done across the UK over several years. Right from 2011, definitely we have that available, and the information still online, where we had a case for action in the annual report for the Chief Medical Officer. And as you can see there, over the last few 12 to 13 years, we have had a range of national action plans also published, 2013 and then 2018. We're currently working through the National Action Plan of 2019 to 2024. And at that point as well, in 2019, there was a UK 20-year vision which was published. And that talked about 9 areas of ambition that we want to focus on. Continue to be a good global partner, for example, minimizing infection, providing safe and effective care for patients, engaging the public on antimicrobial resistance, optimizing antimicrobial use and appropriate use of antimicrobials, which is where I'm going to focus my attention on today around antimicrobial stewardship. There's proactive surveillance on antimicrobial resistance and antimicrobial use in all 4 UK nations. As we know, healthcare has devolved across the UK. The surveillance capabilities are different between the 4 nations, but what is quite key is that we're all working towards the same UK National Action Plan. Across the 4 nations, majority of antibiotic use is in primary care, and antibiotic use has reduced over the years. E. coli continues to be the most common cause of gram-negative bacteremia. In England particularly, we have the National Report on Antimicrobial Use and Resistance, which is published through the EPSRC programme each year. 10 reports have been published so far. And in that report, there is a national surveillance on antimicrobial consumption and resistance, as well as key activities and data on antimicrobial stewardship implementation and awareness activities. The EPSRC report is usually published around World AMR Awareness Week in November of each year. Very recently, the data shows us that we need to continue to take concerted efforts to tackle antimicrobial resistance and also reduce the burden of bloodstream infections. We can see there, for example, that the 30-day all-cause mortality for patients with gram-negative bloodstream infections in 2022. And what's really striking there is the 30% mortality rate for those who have got carbapenems-producing gram-negative bacteria. In terms of antimicrobial consumption, I talked earlier about majority of the prescribing being in primary care, and so you can see there that 72% of consumption is through prescriptions from general practice, 13% from hospital inpatients, and 4% from dental practices, for example, or other community settings, and then 6% from hospital outpatients. You can also see on the right of the slide there that total consumption of antibiotics has been declining for a few years now. We had our peak in consumption in 2014, and that's continued to reduce. We had very significant reduction during COVID for a range of reasons, but you can see that by 2022, those rates were back up again, but still less than where we were in 2019. In terms of primary care prescribing and data, across all the sectors within primary care, so general practice, other community, dental, and overall for total primary care, you can see that trend in reduction. For dental, there was a slight increase during the COVID years, but that's gone back down again since we got back towards post-COVID era. And then in secondary care, there was actually increase in antimicrobial use or antibiotic use during the COVID period, but we've been seeing reductions overall in antibiotic use in secondary care. And within the EPSRC reports, we also have data on antifungals, antiparasitics, and antivirals. So what is antimicrobial stewardship? It is defined as organizational or healthcare-wide approach to promoting and monitoring judicious use of antimicrobials to preserve their future effectiveness. That's a nice definition. But every single person has a role in antimicrobial stewardship as clinicians, as members of the public, or as or any healthcare worker. And that's because we want to optimize the prescribing of antimicrobials to improve the patient outcomes, to reduce antimicrobial resistance, and also to decrease the spread of infections caused by antimicrobial resistance. And every single person has a role in doing this. There are some policy drivers. And what do I mean by policy? These are national activities or government or national organization driven activities or steer or strategy that helps promote and gives us a lever for antimicrobial stewardship. And this includes the Health and Social Care Code of Practice in prevention and control of infections and related guidance, the NHS Long-Term Plan, the UK AMR National Action Plan, which I've previously mentioned. There's a national overprescribing review from NHS England, and there's delivering a net zero NHS as well. All of these provide us with policy drivers and action to be able to take concerted efforts around antimicrobial stewardship. Within the Code of Practice on prevention and control of infections, there are two criteria particularly that are focused around stewardship, and that's criterion 3 and criterion 5. Criterion 3 talks about appropriate antimicrobial use and stewardship to optimize outcomes and to reduce the risk of adverse events and antimicrobial resistance. Criterion 5 says that there is a policy for ensuring that people who have or at risk of developing an infection are identified promptly and receive the appropriate treatment and care to reduce the risk of transmission of infection to other people. And then with the UK National Action Plan, we have targets which are focused on antimicrobial use alongside reducing infections and reducing drug-resistant infections. And for that, it's around reducing antimicrobial use in humans by 15% by 2024. And there is also a target that's focused on, for the animal healthcare sector, around reducing antibiotic use in food-producing animals. NHS England have improvement and assurance schemes, and within that, there are specific ones focused on antimicrobials for both primary and secondary care, and you can see them on the slide there. Very recently, NHS England has also published medicines optimization opportunities for integrated care boards, and within that there are 2 of those opportunities that are relevant to antimicrobial stewardship and antimicrobial resistance. And that's around reducing the course lengths for antimicrobial prescribing and also switching IV antibiotics to oral, which I'll talk about shortly. So evidence-based national antimicrobial stewardship interventions are available, particularly those that are focused on digital resources. The key organizations leading on developing national antimicrobial stewardship interventions across 4 countries include, for England, UK Health Security Agency and NHS England. In Scotland, Health Improvement Scotland. In Wales, Public Health Wales. And in Northern Ireland, Public Health Agency. But also there are several royal colleges, professional bodies, health and education institutions, for example, NICE, CQC, who also have a range of antimicrobial stewardship interventions. A lot of the interventions I'm going to focus on here will be from those that have been led by UKHSA, NHS England, and there's a couple from NICE, for example. So when we talk about antimicrobial stewardship or optimizing antimicrobial use, what do we mean? And this slide here provided from NHS England colleagues is a really good one to summarize that. And that's the importance of avoiding antimicrobials. So how can we avoid antimicrobials? So that we can reduce the clinical need by prevention. So we reduce the clinical need for antimicrobials through prevention activities. In a stewardship context, this includes, for example, vaccination, public health messages, patient empowerment. We can also reduce patient expectation. We can reduce exposure to antimicrobial use by safely reducing overprescribing, using the shortest effective course length, using the narrowest effective spectrum for that infection. And the ways this can be done is through patient risk assessments, decision support tools, including diagnostic tests. If a patient does need an antimicrobial, we can ensure that we optimize the management of that infection. And that's really around investigation, diagnosis, and source control, immediate or deferred treatment, effective drug choice, timely review and revision of the prescription. And for that, we need evidence-based guidelines, which is supported by digital and medical technology, and to ensure that there's equitable access and care and quality of care for patients. NICE have a range of evidence-based guidelines, national guidelines that have been developed, and that includes a variety of guidelines and formats, majority of them available digitally, which is really important for access. And you can see the examples of the focus areas that they have the guidelines on include cellulitis, pneumonia, diabetic foot infection, UTI, as well as COPD, for example, chronic obstructive pulmonary disease. In terms of antimicrobial stewardship tools in primary care, majority of the tools that are available nationally are on the Target Toolkit website, which is part of the Royal College of General Practice web pages. And there is a hub on there which includes a range of training resources, patient information leaflets, audit toolkits, resources for clinicians that you can use in waiting areas, antibiotic and diagnostic guides, and reference tools. Antimicrobial stewardship tools for primary care. Majority of the tools available nationally are on the Target Antibiotics Toolkit hub, which sits on the Royal College of General Practice website. The Antibiotics Toolkit aims to improve the management of infectious diseases through research, intervention, and guidance development, as well as education for professionals and the general public. It includes training resources, patient information leaflets, audit toolkits, antibiotic and diagnostic quick reference tools, resources that can be used in clinical waiting areas, as well as self-assessment checklists. You can see examples of the leaflets there, as well as the web page on the right side of the screen. I will not be going into detail about the patient information leaflets because there is another lecture that focuses on this. I do want to talk about the how-to series though, which is for the management of long-term and repeated antibiotics for the prevention and treatment of COPD and acne, and there are other areas, for example, UTI, that are currently being developed. This is particularly important in the context of structured medication reviews, which can be a focus area for those patients who are on long-term and repeated antibiotics. And within the toolkit, there is a tool that helps you to review patients in the context of SMRs. In terms of focusing on shortest effective courses, there are digital visual analytics available through Prescript for those who are within England, and that is freely accessible for anyone that is part of the NHS. Also on the Futures NHS website, there are key messages for primary care prescribers on how to use the shortest effective courses. There are case studies available, data and evidence bundles, as well as infographics and resources. I do want to talk about some infections which, according to the national guidance that we have, 5-day courses are part of those guidelines. And this includes sore throats, if an antibiotic is indicated, COPD for acute infective exacerbation, acute cough, again, if antibiotic is indicated, community-acquired pneumonia, and then acute sinusitis if antibiotic is indicated. Within secondary care, I'm going to talk about a few tools, and I'm going to start with the Start Smart, Then Focus toolkit for secondary care, and particularly focus on the algorithms that are there, and the importance of knowing that a patient has an evidence of infection by looking and ensuring that we collect accurate history, signs and symptoms assessment, physical examination, looking at the laboratory results, diagnostic test results, and then medical imaging if required. And then if there is a need to start an antimicrobial, the importance of starting smart by assessing the patient, investigating, and then prescribing. And then within 48 to 72 hours, ensuring that we have a focus, again, reviewing that patient. And I'll go to them in detail now. In terms of starting SMART, what do we mean? To assess the patient to make sure that they have clear evidence of infection, to establish whether the patient is likely to benefit from antimicrobials. Because we have to remember that unnecessary use of antimicrobials is actually harming the patient, because we increase their risk of having C. diff, for example, and also resistant organisms. And then if once we've assessed the importance of investigating, so collecting the appropriate cultures or doing the appropriate blood tests and blood cultures before an antimicrobial treatment is started. However, it is important not to delay treatment in the cases of severe sepsis, for example. And then if you need to prescribe, and within that, we need to follow the usual guidelines, ensuring that we're following the local and national guidelines, and then making sure that we are assessing the patient, that we're giving them the best route for antimicrobials, for example. And then once we've done that, to document the evidence of infection, the working diagnosis within the drug chart, within the clinical notes. And then in terms of prescribing, writing down the drug named formulation, for example, and the route within the prescription chart. And then within 48 to 72 hours, that importance of focus and reviewing the patient, and then documenting a clear plan of action. And that we call this the antimicrobial prescribing decision. There are 5 antimicrobial prescribing decision options available. One is to stop the antibiotics if there is no evidence of infection, to switch antibiotics from IV to oral, so intravenous to oral, to change the antibiotics, ideally to narrow, but it may need to be broader, to continue and document the next review date or stop date, or to consider outpatient parenteral antibiotic therapy. I mentioned very briefly earlier around intravenous to IV to intravenous to oral switch, and I'm going to just talk about that very briefly now. In 2022, the National Antimicrobial IV to oral switch criteria for prompt switch was published, and that was done through a consensus process with multidisciplinary group across the UK. And 25 criteria were agreed and categorized into 5 sections, including the timing of the antimicrobial review, the clinical signs and symptoms, infection markers to consider, enteral route, and then special considerations. And then a decision aid was also published alongside this. I think it's important for us to consider the benefits of timely IV to oral switch, and that's importance around reducing the risk of healthcare-associated infections, reducing the risk of making errors in the administration and preparing of intravenous antibiotics. We know that 10% reduction in use of intravenous doses when replaced by oral doses could save the NHS around £10 million per year. Oral antibiotics have a lower carbon footprint. 75% of patients preferred the oral route to IV to intravenous. Having to switch in promptly and appropriately will also free up nursing time to care for patients. And we know the timely IV to oral switch, which is safe, can reduce hospital length of stay as well. There's an opportunity for up to 10% reduction in exposure to broad spectrum intravenous antimicrobials as well. There's also benefits to the clinical team and the patient. So, here we've got this infographic here, which was developed collaboratively. The patient is talking about the tube in their arm being uncomfortable and wanting to go home. The nurse is thinking, well, if I switch to an oral, it can free up my time to care for the patient. The medical team and administrators are thinking, well, if we have appropriate timely IV to oral switch, then it can help the patient get home quicker as well. I'm going to move on now to antibiotic allergy status, which is another important part around antimicrobial stewardship. And this is particularly because we are learning that many patients who have got a penicillin allergy on their records may not be appropriate or may not be as accurate as it should be. So we know that fewer than 10% of patients are likely to have a true allergy to penicillin. And in 2014, a US study found that penicillin allergic patients were found to have more than 20% more Clostridium difficile infections, as well as 40% more MRSA than expected compared to control subjects. And that means that potentially, if we look at that, an extrapolation which is done by the colleagues who looked at this data, it is possible for up to 4 million people across the UK to have an incorrect allergy status record, putting them at an increased risk of harm. And the simple solution to this is making sure that we have a complete and accurate record of drug and allergy history that is taken when we are seeing patients. In terms of what is a true penicillin allergy, that's when there is a serious allergic reaction to penicillin, which is mediated by IgE, or where there are rashes that involve hives or occur with other allergic symptoms, such as wheezing or swelling of the skin, or if there is an anaphylactic reaction. Many people may report an allergy when what they actually experience is non-allergic adverse effects, such as nausea or thrush. There is a way in which pharmacy teams particularly, but all clinical teams can support and help, and that is ensuring that the patient record is accurate in line with the NICE guidelines, to document accurately, to review allergy status during any structured medication reviews. GP practice pharmacy teams can run searches to identify any patients with documented allergy that have since received a penicillin, for example, and then make sure that that is accurately recorded. There's a dental antimicrobial stewardship toolkit, which is available on the .gov website and pulls together a range of resources for dental professionals. This includes detailed prescribing guidelines and summaries, also other guidance and information. But in addition to that, professional development plan templates for prescribers and non-prescribers. There's an audit tool and action planning, and there are also education and training tools. There is a poster that is available that can be used with patients or given to patients as a way to educate around the fact that antibiotics do not cure toothache. Moving quickly now to pharmacy professionals' contribution to antimicrobial resistance. We know, particularly within the UK and in several parts of the world globally, pharmacy professionals have taken a leadership role in tackling antimicrobial resistance. And this includes development of national and local action plans or guidelines to ensure optimal use of antimicrobials. There's importance of collaboration across multidisciplinary teams in the implementation of antimicrobial stewardship, the importance of informed clinical decision making in partnership with patients and multidisciplinary teams. They have a key role around increasing public awareness and providing support and advice for treatment that can occur through pharmacy. Pharmacy teams have been involved in research around diagnostic testing, use of clinical scores, and also there are pathways through community pharmacy settings which are now being used around antimicrobial stewardship and tackling AMR. It's important that pharmacy teams continue to lead as well as receive for themselves high quality education and training to keep up to date with the latest evidence around antimicrobial stewardship and antimicrobial resistance. Particularly for community pharmacy teams, they have a role around infection prevention and promoting antimicrobial stewardship through a range of professional services, including providing patients with high quality information on appropriate use of antimicrobials, and that will be discussed in the patient and public engagement lecture. Raising awareness about correct disposal of antimicrobials, having in place pharmacy-led disposal and collection schemes, offering vaccination programs because these contribute to reducing overall reliance on antimicrobials by preventing infections in the first instance. The use of clinical scoring tools and rapid diagnostic tests as well are important roles. In terms of stewardship in community pharmacy, particularly in England, the Target toolkit has been used and included as part of the policy of the pharmacy quality scheme. And we know that community pharmacy teams have been, over the last 5 years, gaining increased education on antimicrobial stewardship and using the tools through Target to support patients in managing their infections. Also on the Target website, there is a community pharmacy hub, and this flowchart really shows different ways in which the resources available can be used. So, for example, if a patient comes to a pharmacy and they have a respiratory tract infection, through the pharmacy consultation, there are leaflets that can be used with the patient in helping them, particularly for self-limiting infections, such as sore throats. You can use that with the patient, and it includes safety netting and how long the infection may be expected to last for, and will get better without the use of any antimicrobials. The leaflets can be shared with patients. There are QR codes available. There's also self-care leaflets that can be used. If a patient does come in, though, for example, with a prescription, there is also the antibiotic checklist, which pharmacy teams can use with the patient and talk them through side effects possible that they could have, making sure that they have correct information on how to use the antibiotics that they've been given. And again, there is also a flow chart or approach for urinary tract infections, again, where there are resources available for community pharmacy teams to use. There's an antibiotic counseling checklist on the Target website, which is really useful for pharmacy teams when they are counseling patients on the antibiotics that have been prescribed. Pharmacy First is a new initiative in England, launched in 2024, and which is where patients can go directly to pharmacies for support in management of 7 common conditions, including sinusitis, sore throat, earache, infected insect bite, impetigo, shingles, and urinary tract infections. Some of these will need antibiotics, but some of them can be managed without antibiotics, and the pharmacy teams can work with them using the clinical algorithms that have been developed and published to support the patients and accurately manage them or refer them on to other clinicians. In addition to that, the Pharmacy First scheme is being evaluated through a research methodology funded by NIHR and includes 5 work packages around literature review and scoping, economic evaluation, assessing the impact on patient safety, as well as antimicrobial resistance, and then a mixed method analysis. Through it all, the evaluation is underpinned by patient and public involvement and healthcare inequalities in considerations. That leads me on to talking about the importance of understanding and addressing health inequalities and really recommending the importance of looking at the data that is available for your local area and also what is available nationally through the EPSRC reports. Thinking about the ethnicity data of patients with AMR infections, deprivation impact, age group and sex, as well as geographical data on antimicrobial consumption, for example. There are public awareness resources that have been translated into a number of languages and are available digitally as well. In terms of data, there are a range of data and analytical tools available nationally. And this slide here just shows you the range that is available, as well as what sort of data is available through them. These analytical tools, some of them are through private organizations such as RxInfo or community interest groups such as PressSquib, but there are also analytical tools available through NHS England and UK HSA. The National Public Health Data, which is on OHID fingertips, has a whole range of public health data available. Part of that is the AMR local indicators, which is produced by UK HSA. On there, you can see data on antimicrobial stewardship, infection prevention and control, antimicrobial resistance, and a range of other indications as well focused on tackling antimicrobial resistance. Particularly for antimicrobial stewardship, you'll be able to see on the section for antimicrobial stewardship of the main topic area for antimicrobial stewardship, the numbers of antibiotic guardians per 100,000 population per quarter. You'll also be able to see the policy focus area on sequence or assurance schemes on sequence, and on IV to oral switch. So the proportion of patients or percentage of patients still receiving IV antibiotics past the point which they meet the IV to oral switch criteria, which I talked about earlier. You'll also be able to see the intravenous antibiotic prescriptions or prescribing rates for each of the trusts available that you may have an interest in. But on there also, there's data on antimicrobial consumption. There have been several nationwide challenges that have important implications for antimicrobial stewardship. And just in the last year or so, we've had the Group A streptococcus outbreaks in children. We've had a new fluoroquinolone safety alert from MHRA. And then we also had the mycoplasma pneumonia, which happened over this winter. So I think what's really important there is that the impact of outbreaks or new directions or safety alerts on antimicrobial stewardship and in terms of the use of antimicrobials nationally. In developing antimicrobial stewardship interventions, it's really important to focus on using behavioral science, and the most common one that we focus on is the COM-B model, which talks about capability, motivation, and opportunity, and the impact it has on behavior. And examples for capability or actions that you can take around capability is around public and patient empowerment, workforce capability and capacity, For motivation is around policy and commissioning, which I've mentioned some of those earlier, and that supportive oversight that can happen. And then in terms of opportunities around knowledge mobilization of the resources that we have available, using a data-driven improvement approach for all that we do, and also digital and medical technology provides us with good opportunity that can support behavior change. There are antimicrobial stewardship tools available to educate and engage patients and the public, and there is a specific lecture which will focus on this, and so I'm not going to talk any further on that, but really recommend that you listen to that lecture. As I move towards my summary, there is a need for diverse and engaged approaches across disciplines and healthcare infrastructure to combat and tackle antimicrobial resistance. There are a range of future actions that we need to take around infection prevention and control, public engagement and education, surveillance, information for action, innovation and influence, antimicrobial stewardship, which I've focused on today, workforce engagement and education, global action, health inequalities, research, as well as making sure that across all that we do, we're not only focusing on human health, but we're also considering animal health, environment, so the One Health continuum. In terms of further reading, I've provided 3 options there for you to consider, but I highly recommend the collated page of stewardship courses available by BSAC on the FutureLearn platform. And then there are 28 courses available there across antifungal stewardship and a whole range of opportunities there, including the Target Toolkit as well. So more in-depth details about the Target Toolkit as well. In terms of acknowledgement, colleagues across UKHSA, NHS England, ESPA Oversight Group members, also colleagues across UK and globally who have supported the initiation, implementation and evaluations of our various activities. And of course, thank you to the funding from EPSRC for the Digital Hub.